Hi, this is Susan, and this is the second attempt I'm making to record the end part of our presentation from week one. Students reported that the first version that I posted up on Blackboard immediately after class, they were having some technical difficulties with, so imagine that. Anyway, I wanted to go ahead and continue, so I'm redoing this for everyone, and hopefully we won't have any problems. So. Continuing on, we had been talking about some chronic illness issues, some commonalities amongst older adults with chronic illness, and we certainly need to address cognitive functioning and some differences in assessing gerontological differences in cognitive functioning. Uh, it's very common for fluid intelligence, the ability to learn new things, to reason and to abstract and solve problems. Older adults are certainly still capable of doing that, learning new things, of solving abstract problems, etc. But it typically will take the older adult a little bit of a longer time. So there is a natural decline in fluid intelligence as the older adult continues to age. Crystallized intelligence, however, that firmly set knowledge that we have based upon life experiences tends to improve with the older adult. That is the knowledge. It comes from prior learning, past experiences, and our older adults certainly excel in that category. Situations that utilize crystallized intelligence include things like reading comprehension, vocabulary, etc. It's based upon facts. It's rooted in experience. As we age and we accumulate new knowledge and understanding, our crystallized intelligence actually becomes even stronger. So take a look at the other one. It's not uncommon. Most of us know by now that short-term recall memory, things that happened most recently, like yesterday or 2 hours ago, tends to decline with the older adult. But again, our longer-term recall of things that happened a while ago in the past tends to either remain constant or, in fact, improve. Moving on to the next slide, I want to talk about the frail elderly. Frailness is a geriatric syndrome, and individual older adults who are frail and fall into that category are very vulnerable for experiencing additional decline. They're already in a debilitated state, and any additional physiological or emotional insults to them and their persona can in fact precipitate a tremendous decline. There are several definitions for frail elderly, but here's one of them. It's the presence of 3 or more of the following categories: an unexplained weight loss of 10 or more pounds over a period of a year. So it can be a very gradual onset of falling into this category. Overall weakness, poor endurance and energy, slowness, and very low activity. Now, individuals' tendency to fall into this category, our risks increase as we age. Our risks increase if we have any disability or multiple disabilities, multiple chronic illnesses, if we have dementia, people who smoke are at greater risk for becoming frail, and people with a history of depression or other mental illnesses, as well as people who are already underweight. So again, these individuals who fall into the category of the frail elderly have a diminished reserve and ability to respond to additional stressors. So these adults are also they're at risk for needing to be institutionalized if any other type of illness or problem presents themselves. Continuing on with the frail elderly, here's an acronym to assist us in what types of things we want to assess that are related to nutritional indicators for frailness. The acronym is SCALES. S. Have we noticed any sadness or mood changes in the person? Are there changes in cholesterol? Is their albumin low? Normal albumin for an adult is 3.5 to 5 grams per deciliter. And it's natural for our serum albumin to decline somewhat as we age, but certainly if it falls below the 3.5, it's an indicator of nutritional impairment. Okay, again, loss or gain of weight. Are they having eating problems? Are they having problems swallowing? Are they having problems with mastication because their dentures don't fit properly because they've lost weight? Are they having problems with, let's see, what else could be, just preparing meals to begin with? Is that a problem for them? And that brings on the next one, shopping and food preparation problems. Are they unable to get out of the house? Are they relying on someone else to do their shopping for them? So assessing these categories is essential for us to pinpoint potential problems with our older adults' nutritional status. There are also additional assessment tools that can be used for nutritional assessment, and one of them, of course, is posted in consultjerryrn.org. There's a mini nutritional assessment tool there as well. So if you're in the clinical setting and you're caring for an OA, this is something that you're going to certainly want to address. Social support for the older adult is important for lots of reasons, and one of them is their emotional health and well-being. There are a lot of changes that take place with some of our older adults that lend itself to the development of clinical depression. Some of those include, loss of a spouse, inability to drive and get out and be amongst others, living alone, not working anymore. So there's significant factors that can certainly lend themselves to developing depression. So again, social support is very important. Family and friends are a primary source of social support, and it's preferred. It's more natural. It can occur on a more regular basis typically. Other sources of social support come from clubs, churches, senior citizen centers. Perhaps the person is able to afford a membership to a YMCA or YWCA where they can participate in exercise classes or something like that for seniors. But that's all considered semi-formal. And then, of course, there are social welfare agencies and governmental support systems out there for the older adult as well. Elder mistreatment and abuse is a significant issue and concern in our society today. And as our older adult population increases, the incidence of elder mistreatment and abuse will probably increase as well. We know that only 1 in 5 or 1 in 7 cases of elder abuse actually gets reported. So that means that it's occurring more than we are aware of. And there's lots of reasons why older adults who are mistreated do not report it. There are a couple of different types of abuse categories, and I'm going to describe them here. Physical abuse, of course, is pushing, shoving, over-sedating with medications. Restraining older adults is a form of physical abuse. Locking someone in their room and not letting them out would be considered a form of abuse, physical abuse. Neglect is another type, and it is failure to provide things that are necessary for day-to-day living, such as food and clothing, or shelter, or heat or air conditioning, or a fan in the heat of the summer. It also includes failure to provide medications that are necessary for someone with illnesses. Psychological abuse can include intimidating the person. I'm not going to care for you anymore if you don't do this for me. It can include isolation. It can include verbal abuse, such as you're not good for anything anymore. You're worthless, and look at you. You've made a mess all over yourself again with your food. You're sloppy, and on and on and on. And I'm sure I'm being very kind in my terms right now compared to what some elderly probably do actually experience. There's also sexual abuse for the older adult, and that would be anything, any kind of touching or sexual encounters that are non consensual. Whether it's having the older adult perform a sexual act on the other individual non consensually or vice versa. There's financial abuse where the older adult is denied access to their own financial resources. The adult child is power of attorney and has their name included on bank accounts, checking accounts, and things like that. Has to cash the Social Security check for the older adult because the older adult isn't able to get out and drive anymore. And then not providing that individual with access to their own funds. Also, financial abuse includes coercing the older adult to sign over money, to sign a contract, etc. So there are various forms of financial abuse as well. Violation of personal rights is included in this category of mistreatment and abuse. Examples of that could include the right to privacy. We all have the right to some privacy, and denying our older adult a right to that would be an example. Also, denying the individual the right to make some decisions for themselves could be considered a violation of personal rights. Abandonment is there's some parallel concepts there between abandonment and neglect. And abandonment is not, like someone is admitted to a nursing home, and there you go. I don't have to check on mom anymore. She's being taken care of. So even though the adult child, lives, relatively close to where the nursing home is, they never come and see their family member. That would be considered a form of abandonment. More dramatic forms of abandonment include things like dropping somebody off at the grocery store and not picking them up. My understanding is things like that actually do happen. People become totally homeless at that point, and that's another form of abandonment. There's also an issue called self-neglect, and it's fairly common among the older adult population as well. It's when someone starts not taking care of their personal hygiene, where someone starts to not take care of their living environment, where someone doesn't, they're not concerned about medical treatment. They're not concerned about proper nutrition and things like that. So that's another form. It's a form of self-neglect. And again, it's something that as nurses we need to be aware that this does happen. It usually exists comorbidly with a depression, which we know is very common among our older adult population. So, continuing on with mistreatment, there are many, many forms that can be looked at as far as assessment tools for mistreatment. One such tool is available for us on our consultjerryrn.website, and I'm unable to, when I'm in this mode of narrating and showing you a PowerPoint, I'm unable to click on websites and make them live. So I'll ask you to go ahead and do that on your own. But we need to screen for possible mistreatment whenever we are slightly suspicious that there is an issue going on. It includes a thorough history, a social history, a head-to-toe assessment, looking for certain signs and symptoms that are indicated on these assessment tools. Very, very important for us if we are suspicious that an older adult is being abused in some form or manner. We need to make sure that that older adult has a safety plan in place if they feel like they are in imminent danger. If you feel like there's going to be a problem, is there someone you can call? Is there some place that you can go? Can you get out of the house? What to do if they suspect that danger is in fact imminent? We're responsible for identifying any evidence, for photographing bruises, etc., and certainly for reporting suspected or actual abuse. It's the registered nurse's responsibility to do so. Unfortunately, sad to say, if you look at this pie chart, you can see that the largest percentage of abusers and domestic abuse with the older adult population is in fact done by the adult children of the older adult. You can look at the breakdown. This is from the Health and Human Services Department. There might be some minute changes periodically over the years, but again, the adult children are the primary abusers. And just so you know, we will be going to long-term care facilities this semester. Any bruise, skin tear, any type of bruise or skin tear injury is reportable to the director of nursing and to the family when an older adult resides in a nursing home. You actually call the family and say, I don't want to alarm you, but last night when we were assisting your mom to the bathroom, she bumped her elbow, pretty hard on the doorway, and this morning, there's a pretty good sized bruise on her elbow. A lot of older adults tend to bruise fairly easily because of decreased adipose tissue, etc. And we just wanted to let you know that. So that's how carefully the long-term care industry manages and monitors bruises and things like that to help protect this vulnerable population in their facility. Here's a sample exam question. An older adult man is having his blood pressure checked by the nurse at the senior center, where the nurse notes large bruises on both of his upper arms. When questioned by the nurse about the cause of the bruises, the patient responds, "Oh, I must have bumped myself." So, what is the best action by the nurse at this time? What should the nurse do? Take a few minutes, read through the possible answers, and see what you come up with. You can pause the narration if you like, but I'm going to go ahead and give the answer to you now. The answer is number 3. Ask the patient to describe his living situation and usual activities while continuing with the assessment. So again, this is an outpatient, all right? They're at a senior center just here for a blood pressure check, and the nurse notes bruises on arms. So it could be, someone is like like the shaken baby syndrome, it's shaking the older adult by the arms. Typically, there's more than one sign or of evidence of physical abuse. It's usually not just one thing like a bruise. There's going to be something that coexists along with that leads you to suspect potential abuse. But the nurse, instead of right off the bat, like number 1, ask the patient if anyone in his family has been mistreating him, before the nurse asks that question, the nurse should probe a little bit more. Continue with the assessment. Just because you have a bruise doesn't mean that you're abused. Again, older adults tend to, they bruise more easily. Their skin is more fragile. It's thinner. Number 2, report the finding to the state agency responsible for elder abuse. Again, we have not collected enough evidence to do that yet. We need to continue with our assessment. Use a valid, reliable, evidence-based assessment tool to help us in that process. And number 4 is incorrect. Reassure the patient that information he tells the nurse will be kept confidential. We cannot do that. We cannot reassure the patient that what they tell us we will keep private. If that person in fact discloses information that does indicate they are receiving some type of mistreatment, we are responsible for reporting that data. So we do not want to provide false reassurance. Social services for the OA. There are many services that are out there throughout the provided by the government at state and national levels, city levels as well, that provide programs and funding for the older adult population. The Administration on Aging is a part of the Department of Health and Human Services, and they are responsible for many of the OA programs that actually exist. Um, Not testing you on it, but Title III and IV are two big ones. They stem from the Older American Act. Title III funds community-based service systems like senior citizen centers, like Meals on Wheels, and these are resources that are invaluable to many of our older adults throughout our society. Title IV provides funding for the training and the education of individuals who will be involved in the field of aging and caring for older adults. All right. Most older adults do get involved in at least one social or government service at some point in their lives. Um, Go ahead and go to these two live links that I've got on here. They're to the National Institute of Health for Senior Health. All right, so it's specific to the senior adult, the older adult, and these 3 to 4 minute video clips will provide you with important information on Medicare and what is the difference between Medicare A and Medicare Part B. What services are covered under each, and what in fact is Medicare Part D. So please be sure that you do that. You are responsible for that material. This triangle on this screen should actually be turned upside down, and I need to make the note to myself to make sure I change it for next semester. The way I have it here, if you look at the bottom of the triangle, it looks like most older adults live in long-term care facilities, when in fact that is not true at all. The majority of our older adults do in fact live at home. So flip that triangle upside down in your mind if you would, please. Only 5 to 6% of our older adults actually live in long-term care facilities. All right. And the middle portion do participate in adult daycare programs, home health care services, etc. No one would want to go to a nursing home. I mean, it's depressing. It looks depressing. Take a look at this instead. All right, picture this instead: the human flourishing that can occur even in a long-term care setting. Those individuals in a long-term care setting have varying degrees of functional decline and disabilities. Some are more independent than others. Said otherwise, almost all of the older adults can participate in some type of social activity, and good activity staff, good social services, good nursing staffing within a long-term care facility can help each individual reach their optimum level of socialization ability, of functional ability, etc., so that the individual's quality of life can be optimized as much as possible. There are many challenges for gerontological nursing. The underreporting of symptoms is one of them. Many times our older adults will fail to report changes to their healthcare provider or the nurse because they attribute it to, oh, I'm just getting old. That ache and pain that I have is just a part of getting old. They also self-treat themselves by altering their functional status. So if they're having difficulty going upstairs, instead of reporting it as a problem, they move themselves downstairs and they do their best to limit their need to go up and down any types of stairs. Another example would be an older adult who begins to have significant memory problems. Instead of reporting that to their healthcare provider, they instead compensate by making sure they follow a routine, by leaving notes for themselves as reminders, from relying on help from their partner, etc. Whereas perhaps if this older adult mentioned the changes in memory to their healthcare provider, they may in fact be discovered to benefit from early medical treatment. Some of the medications that are out there now, newer medications to help improve memory and prevent further decline in our older adult. Often, as well, diseases are typically, let me restart that sentence, please. Disease symptoms with older adult populations are also atypical. They're not the normal types of symptoms that we would expect. With a urinary tract infection, a middle-aged person will typically experience frequency burning, maybe a fever, all right, an elevated temperature to, our body's response to an infection. That's not necessarily so with the older adult. Typically, the first sign of a urinary tract infection with an older adult is confusion or increased falls. So if we're not aware of that, then we would fail to screen for a urinary tract infection. Very often, an older adult experiences a myocardial infarction with no pain, which was pretty much unheard of with the younger counterpart. Acute appendicitis, they don't experience the acute localized pain that their younger person does. Instead, it's more diffused, and they may not even have any symptoms until the appendix actually perforates. So there are many things that make identification of problems, an illness, specific illness, challenging for the gerontological nurse. The focus of a comprehensive geriatric assessment is for the nurse to be able to determine which interventions might be appropriate to maintain and enhance that individual's functional ability, all right? We want to promote and maintain independence. Before you begin your assessment, the first thing that you want to do is you want to ease the individual's anxiety and address pain and elimination needs. You don't want to proceed with an assessment with an older adult, or anyone for that matter, if they're in excruciating pain or their pain level is just, too high for them to concentrate on what it is that we're trying to accomplish, and if they have to go to the bathroom. So certainly, the first thing that you need to do is address pain and elimination. Make sure they have their assistive devices on or in. Are their hearing aids on and in? Do they have their eyeglasses on, etc.? Make sure that you avoid fatiguing the older adult with this assessment process. Make sure that you break it up into smaller pieces if necessary. And allow the individual adequate time to answer. The information is there. They'll be able to, most likely, be able to provide you with the information you need, but it takes the older adult a little bit more time to process the questions, formulate the answers that they want to give you. And again, make sure that you are using a reliable, evidence-based tool that's specific to the older adult population. So key terms here are initiating the assessment. Make sure you address pain and elimination, primary needs of the adult before you proceed. Avoid fatigue. Make sure the assistive devices are on. Allow adequate time for them to respond, and by all means use an evidence-based assessment tool that's specific for the older adult population. Okay, management of the OA. The nursing process is the same for the older adult as it is for any other age group. There are some nursing diagnoses that may be more pertinent for older adults, but the process of formulating a nursing diagnosis is the same. Again, our planning, we're certainly going to want to identify their strengths and abilities and help incorporate that into whatever our plan is. Whenever possible, we certainly want to include the caregiver in the planning process and make sure that our care is very individualized. In the long-term care setting, you'll hear about the I care plan. It's all about the patient. It's not the nursing care plan. It's the I care plan, the Susan Lowndes care plan. They actively involve the older adult in identifying goals that are realistic and desirable for them, and including them in the discussion of the interventions and how they might meet those goals. Out of all of the healthcare settings, I will have to say that the long-term care setting does the best job in identifying care planning, diagnoses, etc., strategies to achieve those goals the best as far as being very, very patient centered. Um, that's really all I'm going to address as far as follow up from week one. I hope that this presentation runs more smoothly than the others did. And again, as always, if you have any questions about any comments, points that I've gone through on the narrated PowerPoints, please be sure to let me know. Thanks, and I look forward to seeing you in class.